The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to the overview of the PANORAMA Heart Failure Research Study webinar hosted by the Children's Cardiomyopathy Foundation. My name is Gina Petty, and I'm the Director of Family Support and Outreach at CCF. We're glad that you're joining us this afternoon and hope that the presentation is helpful and informative. Before I turn the presentation over to our guest presenter, Dr. Shaddy, we have a few housekeeping notes before we begin. If at any point during the presentation you need technical assistance, please type your concern in the chat window, which is on your control panel on the right-hand side of your screen. If you have any audio issues, you should be able to switch between using your computer speakers and calling in with a phone if needed. In order to provide the highest quality session today and avoid background noises, we are in listen-only mode. Any questions you have for Dr. Shaddy can be submitted via the question box, which is on the control panel. We'll be taking questions during the end of the presentation, but please feel free to submit your questions at any time that you think of them throughout the presentation, and we'll go through them at the conclusion of the talk. We will also be recording this webinar today and posting it online, so you'll be able to refer back to the information and access it at a later date if you wish. Now I'd like to introduce our presenter. Dr. Robert Shaddy is the Pasadena Guild Chair, Pediatrician-in-Chief, and Senior Vice President of Academic Affairs at Children's Hospital Los Angeles and Chair of the Department of Pediatrics at the Keck School of Medicine of the University of Southern California. As Pediatrician-in-Chief and Senior Vice President of Academic Affairs, he provides oversight for faculty appointments as well as educational and research activities at Children's Hospital Los Angeles, including those performed at the Saban Research Institute, CHLA's freestanding research facility dedicated to exploring and addressing the most pressing national child health issues. In his role as Chair of Pediatrics, Dr. Shaddy oversees department faculty at CHLA, LAC, and USC Medical Center campuses. Dr. Shaddy is recognized internationally for his research in pediatric heart failure and heart transplantation. He has authored or co-authored more than 200 manuscripts in addition to 23 book chapters and 7 books about pediatric cardiology and heart failure. He is currently the chair of the executive committee of the ongoing multinational PANORAMA Pediatric Heart Failure Study. Thank you so much for joining us today, Dr. Shaddy. We really appreciate it. And welcome.
All right. Well, thank you, and thanks to the CCF for doing this, and for all of you for joining. So, I want to see if my slides come up now, and if confirm that those are now visible to everyone.
Yes, they are. Yep. Thank you.
Okay. So I'll try and drive this from here. So thank you all for joining, and I'm going to give a brief presentation about the study and then be available to answer questions at the end. So I'm eager to hear from you. So in the interest of full disclosure, I am a paid consultant for Novartis in my role as being the chair of the executive committee of this trial. And I'll talk about the trial and where we got to where we are today. So to tell you a little bit about this medication, which is now called Entresto or LCZ696, the new moiety in this drug is sacubitril. And sacubitril is a drug that has never been used in heart failure in adults or children until Entresto came along. And what a sacubitril does is it blocks the breakdown of a peptide called B-type natriuretic peptide. This is a cardiovascular active protein that is in the body. We actually use this to measure how people are doing. It's a biomarker, and as such, it is something that mediates cardiovascular response to stress. And sacubitril blocks the breakdown, which is neprilysin breaks down BNP, sacubitril blocks that. So what LCZ is a combination drug, and it's a first-in-class angiotensin receptor and neprilysin inhibitor. And the angiotensin receptor blocker is actually valsartan, and we use this in heart failure mainly in patients who cannot tolerate ACE inhibitors like enalapril or captopril, and we add neprilysin inhibitor sacubitril to this, and it comes up with this combination drug called LCZ696 or Entresto. And the main study, the Paradigm HF trial, was the main study that was completed by Novartis a few years ago and published in New England Journal of Medicine. And what it was a head-to-head trial comparing enalapril to LCZ696 with the primary endpoint of heart failure hospitalization or mortality. And as you can see, over 8,000 adults were randomized into this, half going to LCZ and half to enalapril. And there was a significant benefit on the primary endpoint of LCZ compared to enalapril worldwide. And on the basis of this, the FDA approved LCZ696 for the treatment of heart failure in adults. And the current recommendations in the US are that symptomatic adults with heart failure with reduced ejection fraction, that's called HFrEF, heart failure with reduced ejection fraction, meaning that the heart function is decreased, should switch from a stable regimen of an ACE inhibitor or an ARB like valsartan to LCZ696. So on the basis of this, when this was coming about, I worked with Novartis to set up this trial, which is a multi-center open label study to evaluate the safety, tolerability, pharmacokinetics, and pharmacodynamics of LCZ696 that is then followed by a 52-week or 1-year randomized, double-blind, parallel group, active controlled study to evaluate the efficacy and safety of LCZ696 compared with enalapril in children ages from 1 month to less than 18 years of age who have heart failure due to systemic left ventricular systolic dysfunction. And I'll show you that it's a sort of a complicated, long-winded way to say we're going to study how the drug works in children and then compare it to enalapril. And this is the study design that we actually presented last year in Barcelona at the European Society of Cardiology. And it's a unique study design that we approved with both the FDA in the US and the European Medicines Association in Europe. And there's a part 1 to the trial, which has 3 different age groups. We have age 6 to 18 years of age. We have group 2, group 1, 6 years of age. And then group 3 is 1 month to 1 year. And we started with the older age group looking at the pharmacokinetics and pharmacodynamics of it. And once patients completed that and the FDA approved it, we then would move patients into part 2, which is the head-to-head trial of the LCZ696, not placebo-controlled, but randomized to either LCZ696 or enalapril, with the goal of having 180 children in each group. So over the last year, we have completed the pharmacokinetic and pharmacodynamic portion and moved into phase 2, part 2, and have 91 patients currently enrolled worldwide in that part of the trial. We then completed the part 1 of the age 1 to 6-year-old, the group 2 age group, and then have enrolled today 23 patients enrolled in that worldwide. We currently have 23 countries with 102 sites around the world, and our goal is to get to 29 countries and initially 106 sites, but we're actually going to end up, if we're successful, of more than 106 sites to enroll these 360 patients. So here's some of the study protocol. Again, the purpose of this study is to determine whether children with heart failure will derive greater clinical treatment benefit assessed by a global rank endpoint with LCZ compared to enalapril over 52-week treatment duration. And it has those 2 parts I mentioned. Part 1 will confirm the dose, the appropriate dose to use, and part 2 will then use the data from part 1 to assess the efficacy and safety of LCZ compared to enalapril. Part 1, again, is the PK/PD portion, and part 2 is the randomized trial between enalapril and LCZ. The population is children 1 to 18 years of age. They can either be inpatient in the hospital or outpatient, and they have to have a systemic left ventricle that has systolic dysfunction. And initially, we set this up to have an ejection fraction less than or equal to 40% or a fractional shortening by echo less than 20%. we have submitted an amendment to liberalize this a little bit for the left ventricular ejection fraction may be less than 45%, normal being greater than 55, and a fractional shortening less than or equal to 22.5%. We just have submitted that to the sites and approved it by the FDA, so that's going to be submitted to the IRBs at all of the different areas. And then we'll have 18 patients enrolled in part 1 at least, and 360 in part 2. Inclusion criteria, we need to have obviously written informed consent by the parents or legal guardians. They can be male or female, inpatient or outpatient, with 1 month to less than 18 years of age, and they have to have chronic heart failure resulting from left ventricular systolic dysfunction and receiving chronic heart failure in those who have been on therapy. For those who are newly diagnosed, they can be on no medications and can be randomized into the study of enalapril versus LCZ 696. They have had to have had symptoms in the past at any time. So if they're older children, they have to be New York Heart Association class 2 to 4. If they're younger children, there's a Ross heart failure classification that we use, but they don't have to be symptomatic at the time of enrollment, but they have had to have symptoms in the past. In addition, they have to have the systemic left ventricular ejection fraction that's decreased, that's measured by echo. They can be by MRI, they can be used by, also done by MUGA or a left ventricular angiogram within 1 month prior to enrollment. And they have to have biventricular physiology with the systemic left ventricle. So that's important because we do have patients who are single ventricle, who have a systemic right ventricle, and those are patients who are not candidates for enrollment in this trial. So exclusion criteria are patients with a single ventricle or a systemic right ventricle, patients who are listed for heart transplantation in an urgent status, who are waiting for transplant on inotropes or with an LVAD device in place at time of entry. Number 3, they can't have sustained or symptomatic dysrhythmias that are uncontrolled with drug or device therapy. Number 4, exclusion is they have had a cardiovascular surgery or percutaneous intervention to palliate or correct a congenital cardiovascular malformation within 3 months of the screening. And if patients are, if they're anticipated to undergo corrective heart surgery during the time of the study, the 12 months of the study, that's also an exclusion criteria. Say they have a surgery scheduled in 6 months or something. Also, number 5, patients with unoperated obstructive or severe valve disease or significant aortic arch obstruction are not candidates. And patients with restrictive or hypertrophic cardiomyopathy are also excluded. So for more information on this, we have a site on clinicaltrials.gov that talks about the trial. It goes over it and gives you ways to contact Novartis to be enrolled in this, and it'll be able to get you sites that are near where we're living that may be doing this. Most major pediatric cardiology centers are now in the U.S. are part of this. Not all of them are, so we could get you those sites that are closest to you to contact them if you're interested in enrollment. So really, I want to thank all of you for participating in this. I want to thank all of you for advocating for children with cardiomyopathy through the CCF. I want to thank you for understanding the potential benefits of research to children and their families, for realizing how important research is for developing better management strategies for children with cardiomyopathy, for realizing how important research is for improving the lives of children with cardiomyopathy, and for considering inclusion of children into important research studies such as PANORAMA HF. So that's the only presentation that I have planned, but I'm available and eager to answer any questions that you may have.
Thanks so much, Dr. Shaddy. That was very informative. I'm going to go ahead and invite people to go ahead and continue to submit questions. We do have a few to get us started, but if anyone on the call is listening and wants to submit additional questions, feel free, and then we'll go through them as well. So the first question is, is kind of a logistical question, but if a patient who is treated at a center that is not a participating site, are they still eligible to enroll via another a participating site that's on the list on the clinical trials listing?
So I think the way that would have to work is all of your visits would have to happen at another site. So you could continue to have care delivered at a site that you're currently at, but you have to, all the study protocol work has to be done at an approved site that has IRB approval and where all the testing is approved, et cetera. So you can't have it done from a distance. It has to be, those testings have to be done at an approved site.
Okay. Okay. Another question is over the course of the study being 52 weeks, can you elaborate a little bit more on how many visits that entails and what type of procedures happen within that the study?
Yeah, so that's a great question. There's the medications are started at a lowish dose, depending on what medication the child may be on at the time of entry into the study. They are not started at the maximal dose of enalapril or LCZ of the study drug. And so it will require some initial blood work and some initial visits early on that are every 2 weeks to a month early on. After that, the visits are stretched out to every 3 months after that. And so there will be several visits during the study. There will have to be labs drawn for safety during the study, since this is a drug that has not been used in children before. I don't know the exact number of visits, but there are several visits during the year.
Okay, great. Thank you. Another question is, if a child has a left ventricular non-compaction diagnosis, are they eligible to participate?
If the child has a dilated cardiomyopathy with reduced ejection fraction and has LV non-compaction and meets all other criteria, yes, that patient would be included, could be included.
Okay, great. Another question is, does the patient have to go back on enalapril after the conclusion, even if they have received the approved drug during the study?
So also a really good question. So at the end, when a child gets through with their 52 weeks of it, not knowing which medication they are on, they will then have an option to either go back onto enalapril if they had been on it before, or even if they hadn't, to choose that. Or there's also going to be, and we hope to have this rolled out in January, what's called an open label extension, where they would be then allowed to go on to the LCZ 696, not knowing whether they were on it during the 52-week period. And that would be provided free of charge by Novartis for those who want to go into the open label extension. At the end of the study of that 52-week period for that child, we will not be able to let the family or the child know which medication they were on until the last child of the study completes the 52-week period of the trial. So there are people currently right now who are completing the trial and are looking at what medication they're going to end up on, but they will not know what medication they were on until the entire study is completed, which may still be a year or two away. So that's how these kind of trials work.
Okay. Okay, great. Another question is, if the child is already on 2 mg dose twice a day, do they have to go back to the minimal dosage to start the study?
No, that's a great question. That's a very insightful question. No, they don't. So what we do is we look at how much they're on, and we have tables that we provide the families and the principal investigators at every site that says if you're on this much enalapril, then you can start at maybe level 3 out of 4 for that, so that you only have one up titration visit. And so this person obviously understands that probably when they were started on enalapril, they were started at a lower dose and gradually increased. And so if you're at a medium dose now, depending what your child weighs, we have a milligram per kilogram table, then you could start at level 2 or level 3 potentially, and then just have one up titration visit and dose instead of several to start at the restart at the bottom. So that's very insightful and correct.
Okay, great. There's a question here asking about the risks of Entresto versus enalapril, and could you comment a little bit about the comparison of those?
Yeah, so in the adult trials, there was actually less bad side effects, adverse effects from the Entresto with regard to things like angioedema. There are these things with ACE inhibitors that are more common in adults than in children, and one of them is angioedema, which is sort of a response, an allergic response almost to the medication that can be serious. Much less of that was seen with Entresto than there was with ACE inhibitors. There was actually a little less problems with kidney function and high blood potassium with Entresto. There was more lowering of the blood pressure with Entresto than there was with enalapril. So when I talk to families about this, we say we do need to monitor for the blood pressure issue because there seems to be more lowering of the blood pressure with Entresto than enalapril. We are monitoring all of this with a separate data and safety monitoring committee that reviews all of the adverse effects throughout this study. And as of yet, there's not been any significant concerns that have warranted any changes in the study protocol from the data and safety monitoring committee. So since this drug has never been used in children before, there are still potential side effects that we don't even know about. And so that's why we need to track it. But from an adult standpoint, the blood pressure one is the one we're most concerned about. Neprilysin is something that's throughout the body, not just in the heart. It's in the brain, it's in the liver, it's in the kidney. So we need to monitor all parts of the patients and to track this, which is happening in adults as well. Even though it's now being used, there's post-marketing monitoring that's going on to be sure that no surprises show up later, as it happens with every new drug, because these new drugs, sometimes some things can take years to show up, so that it's being monitored closely as well.
Okay, great. So kind of a follow-up question that's related to that is, if a child participating shows a decline while being on the study, or what kind of how does that work as far as leaving the study or disenrolling, or what are the options around that?
Yeah, so the primary concern is the safety of the child and the appropriate treatment of the child. And if in the estimate of the family and your doctor who's you're working with, they think that getting out of the study is a good idea, you absolutely have the right to get out of the study. You need to be treated as you would in any situation, regardless of whether you're in the study or not. So anyone always has the right, for any reason, to say, I don't want to be in the study anymore, and then they're allowed out of the study. And then that comes up to whether you want to work with your doctor to get back onto a different drug or take more of a different drug or whatever. That's up to you and your doctor. But you absolutely have the right at any time to say, I don't want to be in the study anymore. I want to just go back onto enalapril if you're on enalapril before, to do something else. That's absolutely the right you have.
Okay, great. Another question is, has there been any conclusions for children from the first part of the study showing improvement, or was that really more around the dosage piece of it?
The first part was only around determining dosage. And what the Data and Safety Monitoring Committee does is they look periodically at the patients who've been enrolled, and they then unblind it to themselves. They look and say, okay, so is one better than the other? And if one looks like it's better than the other, or if one's having more side effects than the other, then they can unblind it and say, we need to stop the study because we're having problems here, or one is so much better than the other, we prove it already, we don't need to do the study anymore. They have not stopped the study. They have said continue with the study as is. We do not see any reason to stop it either for harm or for benefit yet. So they're tracking that to see if there is any evidence of one over the other. So as of yet, no, we don't have any signal saying one is better or worse than the other.
Okay. Is there any known correlation between the connection of Entresto to later on developing, being at risk for developing Alzheimer's?
So that's a great question, and one that people are watching for. So as I said, that neprilysin does have effects in the brain, and people are watching this to see if there's any relationship between that and whether that could impact the development of Alzheimer's. And that is being watched very closely by the FDA and by Novartis and by the people running the studies and after the studies. And as of yet, there's been no correlation seen whatsoever, but that is something that that Novartis is going to continue to watch for.
Okay, great, thank you. Another question is, can you comment on how long enalapril has been used to treat children with cardiomyopathy versus now the Entresto?
Well, I've been using enalapril at least 20 years. And I know I did my first study with captopril back, I think, in 1988, so 30 years ago. So ACE inhibitors have been around for 30 years. And Entresto's been around for a year, 1 to 2 years. So that's the difference in that. So we have much more experience with one over the other.
And how long has Entresto been utilized for adult therapy?
Just 1 to 2 years. The PARADIGM-HF trial was completed in 2014, and I think FDA approval came through in 2015 or 16, so maybe 3 years. I don't know the exact date, but not for very long. Until the PARADIGM-HF trial was completed, which was published in 2014. The Entresto was not being used. So it was based on that it then became FDA approved and could be used in adults with heart failure. So I think it's only been about 3 years. And now with children, we've only been using it in this study for a year and a half or so.
Okay, great. This is a question from a parent whose children participated in the study. They completed the study in August. The question is, when would you anticipate the completion of the trial, as they are very anxious to find out which medication they received during the trial?
Well, we have a deadline to get this stuff to the FDA in about 2.5 years. So we're hoping to have it completed before then, one way or the other. So we are working hard and continuing to open sites and encourage enrollment so that we can get the 360 patients enrolled. We've still got a ways to go. There's a lot of uncertainty with that. There's always challenges around that. I ran a trial many years ago, the pediatric carvedilol trial at 28 centers in the U.S., and it took us 4 years to enroll 161 patients. We're hopeful that we're going to be able to enroll our 360 in a much shorter time frame, but there's no way to predict that. I'd only be guessing because I don't know, but we're hoping to have enrollment done within the next year and a half if we're lucky and we're diligent.
Okay. Thank you. Are there any other drugs being used that affect the brain in the same way as this drug?
Not that I know of. I think that Not that I know of, no.
Okay. Okay. Another question is, after pulmonary artery banding procedure for dilated cardiomyopathy patients, if the ejection fraction gets lower, would they be eligible to participate, I believe is the question.
Yeah, I would think they would. I've not been asked about that yet for this study, but I would think that one of the inclusion criteria I mentioned was they've got to be 3 months out from an interventional procedure. But if they are 3 months out from that and the ejection fraction is still meets criteria, then I would think they would be candidates. Yes.
Mm-hmm. Okay. Okay, great. I'm just going to ask for a final call of questions. I think we worked our way through all of the queue, so thank you all for submitting questions. We'll take another minute, and if anybody else wants to type as we're kind of just sharing some final thoughts, go ahead and submit those questions now. So I guess just to recap, as far as next steps for people who might be interested, Dr. Shaddy is the best way to locate a center to go on to the clinical trials website.
Or you can contact me directly. I'm in Children's Hospital Los Angeles. I'd be happy to help you with that. So, or your cardiologist might know as well. But I'd be happy to be available to you at CHLA. I'm the chair of the executive committee, so I would be able to locate a site and help with that. So I'd be happy to be involved as well. The website, the Novartis would as well. They don't have all the sites listed, and part of that is that the sites our new sites are coming on at different times. Some sites are coming off, and so it's a moving target a bit. But we could, at the time that you're interested, we could get you the most recent list of that and be able to help you with that. So I can do that. Novartis can do that. Whatever's easiest.
Okay, that sounds great. So, and what we can do is I'll send out the link to all of the attendees today with the link to this recording, and then we'll include those other contact resources for anyone who is interested in connecting with additional questions or for any other next step kind of guidance. So, thank you again so much, Dr. Shaddy. We really appreciate you spending some time with us to share this really important information on this trial.
Yeah, and if other questions or come up, those are great questions you had, and thanks to the person who had enrolled in the study. I hope your experience was a good one. But if other questions come up, I'm available to answer questions, and if other questions after you hang up come up, so please don't hesitate.
Thank you so much again. Thanks, everybody, for joining.
Thanks, everybody. Okay, bye-bye now.
Have a great afternoon. Thanks, everyone. Bye-bye.